Welcome to this talk. The subject we're going to look at this morning is respiratory infections, infections involving the respiratory tract. Now we're going to start off by talking about infections of the upper respiratory tract, but most of the time we're going to focus on infection in the lung tissue itself, the condition called pneumonia. But to set the background, let's think about respiratory infections in general, thinking about upper respiratory tract infections to begin with. So perhaps the one that you've all had, well of course you've all had, come across it all the time, is the common cold, a respiratory tract infection. And this is a viral condition, therefore we cannot treat it. We cannot cure the common cold. We have no effective antiviral drugs against the rhinoviruses. Rhino means to do with the nose, virus clearly. So the common cold, what causes it? Several different viruses, several different types of rhinovirus. Now because there's several different types of virus, what this means is you can get a cold 1 week and okay, you'll recover from it because you'll make antibodies to it. You make antibodies to the virus and the antibodies kill the virus, get rid of it, gets rid of the virus and you get better. But then because in theory then you can catch another virus, you see, which is different, which you may not be immune to. That's why some people unfortunately can get 1 or 2 colds in a winter. So several different viruses can cause it. And not only are there several different viruses, but the genetic nature of these viruses change. And if the genetic nature of the virus changes, it means the proteinaceous outside coating of the virus can also change. And that means that a virus which your immune system recognised and dealt with last year can, in principle, in theory, reinfect you the year after, because there's been sufficient genetic change in the virus for the immune system no longer to be fully effective against it. And there's 2 ways genetic change can occur in cold viruses, in fact in any virus really. These are called genetic shift and genetic drift. Now what do these terms mean? Well, in a genetic shift, there's a radical change in the genetic material, resulting in a radical change in the nature of the virus. This is what is often called a mutation. The virus will mutate into a completely different form. And that form, people will have no immunity to. There'll be no herd immunity to that particular type of virus. And the same can happen with influenza viruses as well, with the flu virus. You can get sudden genetic changes in that, mutations in that, genetic shift effects. The other type we mentioned was genetic drift. What do we mean by genetic drift? Well, drift is the way that the virus just changes gradually and slowly, very, very minor mutations or minor genetic changes in it. And if there's a minor change, then the odds are you'll still be immune to it because we enjoy a reasonable amount of cross-immunity. Immunity is specific, but it's not absolutely specific. So if it's changed a little bit, then perhaps you'll still be immune to it. But if it changes a lot, you won't be, and you can get the same virus again. Now, talking about influenza viruses, in 1919, an influenza virus mutated, and it caused an absolute pandemic. The figures of how many people died are debated, but it's probably around 20 million. Certainly more than were killed in the First World War, were killed in the influenza pandemic. Pandemic is an infection which affects the whole world that occurred in 1919, and about 20 million people died from that. Many of whom were young, fit adults who developed it. Complications developed, set in, such as pneumonia. Of course, in those days antibiotics weren't available. And about 20 million people died from flu, from an influenza virus, because it radically changed its nature and people had no immunity to it. So many different viruses can cause colds and influenza, and even those viruses, there can be genetic shift and drift of those viruses. And you may have come across flu vaccinations. In flu vaccines, what people do is they actually mix up they make a vaccine against 3 of the influenza viruses that are around. But of course there's many more than 3 influenza viruses around. So what they do is, basically, it's an educated guess, but it's a guess nevertheless. They guess what flu virus is going to be causing influenza next winter, and you immunise people against those 3 common viruses, and usually they get it pretty well right. But it is still a guess because you don't know which of the dozen or so, or more, I'm not sure, there's several viruses around, which ones are going to be causing the outbreaks next winter. So viruses, different types, genetic shift and drift of those viruses can have infection with the possibility of reinfection, unfortunately. So several different viruses, genetic shift and drift, changing the nature of those viruses. Now thinking about the rhinoviruses, they actually damage the epithelial cells of the nasal cavity, and this causes inflammation. So the viruses directly insult the epithelial cells in the nose, causing inflammation. And it's this inflammation that causes the features that we call a cold. Characteristic watery discharge, for example. Nasal irritation due to the inflammation. And possible bacterial secondary infection. And as we'll see, a common problem in the respiratory system is that bacterial infection can superimpose itself on viral infection. But the viral condition itself you would normally abate within a few days as we develop cellular immunity to the virus. But the key thing is, may lead to secondary bacterial infections, typically streptococcal infections. But staphylococcal and even pneumococcal infections are possible. Pneumococcal, of course, the bacteria which most commonly causes pneumonia. So where does this leave treatment and advising people who have colds and things like that? Well, there's no point taking antibiotics for a cold because it's a virus. But in some people who may be at particular risk of developing secondary bacterial infection, for example, those with chronic bronchitis, then possibly it's worth giving them antibiotic cover when they've got a cold, because it's very likely that secondary bacterial infection could occur, resulting in an exacerbation of chronic bronchitis, an acute exacerbation of chronic bronchitis. Also, these people, it's worth immunising against influenza type viruses as well, if that vaccine is available. Because I'm sure we've all experienced this, you get a cold, but then you start getting sinusitis, and then you start bringing up some green sputum. And the green sputum is characteristic of bacterial infection. So what you need to do is assess the risk of secondary bacterial infection to the individual and treat or not treat according to your assessment of that risk. So secondary bacterial infection, common after viral infection. Now I've put various things here. Tonsillitis, for example, is inflammation of the tonsils due to infection, usually. Pharyngitis, inflammation of the pharynx. Laryngitis, affecting the larynx and the vocal cords. Tracheitis, affecting the trachea. And if you remember your anatomy, there's a connection from the pharynx to the inner ear. So these infections can lead to inflammation, infection of the middle ear, otitis media. And I've grouped all these together because, remember, the respiratory tract is a continuous surface without boundaries. So in principle, an infection which exists in your tonsils can go into your trachea, or it can go for a sore throat can develop into a tracheitis, or a cold can develop into a laryngitis, because the bacteria is free to move around the tract. And if the infection is bad enough, pus may be present as well. Inflammation will usually be present from a virus or a bacteria, but pus and thick mucus secretions, typical, can develop with bacterial infections. Certainly the mucus. The pus is a more serious sign. And classically, with bacterial infection, you get green or yellow sputum. So that covers what we wanted to say about common upper respiratory tract infections, the sort that certainly people in the United Kingdom get once or twice a year every winter. I want to move on now to looking at pneumonia specifically. Now, in the past, pneumonia killed a lot of young people in Western countries, killed a lot of children in Western countries. But with antibiotics, this is much less common now. So, although the overall incidence in the UK of pneumonia is not a great deal different to what it has been in the past, the age distribution has changed. So, less children are getting it now and more older people are getting it. This is a huge problem in developing countries. It's a huge poverty-related problem because the most common cause of death in children, preventable cause of death in young children, is probably gastroenteritis, diarrhoea. But pneumonia is probably second. Chest infections is probably the second biggest killer of children in the world. So it must be taken very seriously in children. So what I want to do now is run through the principles of pneumonia, paying attention to how we can prevent it, that's our role as health educators, and paying attention to how we can treat it, because that's relevant for us to know about as well. So let's start thinking about the condition called pneumonia. And let's start off with some sort of definition. Pneumonia is an acute inflammatory process, and the key thing is it involves the substance of the lung. So the other infections we've talked about so far are involving the airways, but not the substance of the lung itself, not the alveoli. So bronchitis is inflammation of the bronchial passages, but it only becomes pneumonia when it involves the substance of the lung, when it involves the alveoli. And of course the bronchial passages will be affected as well. So it's an infection of the bronchial passages and the alveoli. These aren't separate definitions, they're all really part of the same thing. There tends to be consolidation of the alveoli spaces with inflammatory exudate. Consolidation. Now what does this term consolidation mean? Consolidation really means to make solid. So the alveoli, because they fill up with fluids and things, become solid. And of course, if they're full of fluid and they're solid, you can't get air in and out of them, so that part of the lung is no longer effective. And that's where the infection is as well. The infection is in the areas which have been made solid. And you can get patchy consolidation, little bits of consolidation all over the place, or you can get areas of lobar consolidation, as we'll see in a minute. So consolidation to make solid, that's an important thing to understand. So consolidation of the alveoli spaces. And what tends to what tends to consolidate them is the inflammatory exudates. The bacteria causes the inflammation, then the body reacts to that. Sorry, the bacteria causes the insult, and the body reacts to that insult by an inflammatory response. I'll say that again. The bacteria causes the insult, and the body responds to the insult with the inflammatory response, part of which is production of inflammatory exudates. The trouble is in the lung, these collect in the air spaces. Another definition you might read is any lung condition in which the alveoli become filled with fluid or blood or white blood cells or anything that fills the alveoli basically. So here we've got a diagram of some terminal bronchioles here, and the alveoli, or the air sacs in the lung. And of course, normally, air, which is high in oxygen but low in carbon dioxide, is breathed in. There's gaseous exchange. The oxygen goes into the blood. The carbon dioxide comes back from the blood. And then the air lower in oxygen but higher in carbon dioxide is then breathed out. normal gaseous exchange. But of course this requires on the fact that there's air in the alveoli. In pneumonia, the alveoli consolidate, are made solid. So we get this sort of position here. Inflammation in the terminal bronchioles filled up with inflammatory exudate, and the alveoli filled up, in fact the whole area really filled up with, the whole area can become consolidated. But I think you can see clearly here, if these are full of fluid and other things, if they're consolidated, then gaseous exchange is not possible. So this is where the infection is, causing the alveoli to fill up with fluid. This is the tissue of the lung. It's infected, it's inflamed, and it's consolidated. The nature of the pathology in pneumonia. And this is a diagram of what you would see in a microscope if you look at a section of lung. These are the alveoli, the air spaces. Here, this is why lungs are so spongy, of course, because they're full of air. And this is the wall of a bronchiole, and this is the lumen here of the bronchiole, and these are the air spaces. Of course, there'd be blood vessels and things as well, but this is what you see. So the key thing is air spaces for gaseous exchange to take place normally. But in pneumonia, if you look at a slide of lung which is consolidated, then the alveoli are full of inflammatory exudate. In fact, the whole area may be consolidated, depending on the severity of the condition. And they may be pus cells and other inflammatory changes inside the larger airways, inside the bronchioles. So in pneumonia, inflammation, infection in the bronchioles, in the bronchial tree, and consolidation of the alveoli. So I don't think you need to be too advanced to realise that pulmonary ventilation and diffusion will be impaired because of the consolidation. And you can see straight away this may lead to hypoxia. Hypoxemia, lack of oxygen in the blood, resulting in hypoxia, lack of oxygen at the level of the tissues. Now, the next thing I want to do is to try and classify pneumonia. And there's two ways this can be done. The first way it is classified is anatomical, and it is classified according to the parts of the lung that are infected. The second way to classify it is by the etiological organism, by the bug which is causing the condition. And both are useful ways. Perhaps the most useful really is the bug, because if you know the organism, then you've got a fair idea of how to treat it in terms of antibiotic therapy. But it's useful to know about the difference between bronchopneumonia and lobal pneumonia. Now, let's deal with bronchopneumonia first. Bronchopneumonia affects all of the bronchial tree, all over on both sides of the lungs. So it affects both sides of the lungs, all over the bronchial tree. And you get diffuse areas of consolidation all over. Sometimes it's worse at the bases because the fluid tends to settle down, so the bases might sound more crackly than the higher parts of the lung tissue. The second sort, lobar pneumonia, affects one lobe of the lung, and the rest of the lung should be okay. So bronchopneumonia affecting all of the bronchial tree, lobar pneumonia affecting a particular lobe. And I'll just show you an anatomical section now of a lung which shows that the lung is in different lobes. So here we're looking at a rather old actually section of lung. And I think it's the left one because it seems to be in two lobes. So the bottom part here is one lobe and the top part is another lobe. And I think round here you can see the division between the two lobes. Round there like that. The two are anatomically separated. And indeed it's fortunate they are, because in a lobal pneumonia, one lobe is affected. And very often the infection stops when it becomes to the boundary between two lobes. If the lung was made out of one piece, then the whole lung would become infected and the condition would be that much more serious. So it seems that the design of the lungs, at least in part, is to facilitate isolation of infection and give us a reasonable chance of survival. Whereas if the whole lung became completely consolidated and infected, then survival wouldn't really be very likely. So a very interesting aspect of the design of the lung there. So let's now differentiate between broncho and lobar pneumonia diagrammatically. The first diagram shows bronchopneumonia. And as we've said, the infection, the inflammation and the consolidation is diffuse throughout the bronchial tree. Bronchopneumonia, bronchial tree. So it tends to be all over the place. Sometimes, as we've said, more severe at the bases, not always. So bronchopneumonia, the whole of both lungs tends to be affected. But with a lobar pneumonia, it's one lobe of the lung that's affected. Now the right lung is in 3 lobes, the left lung is in 2. And in lobar pneumonia, it's one lobe, as the name suggests, lobar, which is affected. And usually, in a lobar pneumonia, the pleura is involved as well, because of course this is surrounded by the visceral and parietal pleural membranes. And if the whole lobe is infected, then the pleural membranes often become inflamed and infected as well. And this is when it becomes very painful, because the pleural membranes have to move against each other to facilitate respiration, and if they're inflamed it becomes very painful. And sometimes you'll see a third classification of pneumonia, a so-called segmental pneumonia. And this is when typically, for example, if there's inhalation of vomit and you get some foreign material, infected material here, then everything distal to that blockage or that infection becomes infected. So a segment of the lung, typically a segment supplied by one affected bronchial passage, often one of the larger bronchial passages, causing the segment of the lung to be infected, a segmental pneumonia. But the main types, the broncho and the lobar. This X-ray shows a left upper lobar pneumonia. Now if you look at the density on this side, the dark of course is the air. If you can compare that to here, I think you can see it's much lighter here. This area here, especially this bit, is much lighter colour than this side. And as well as that, radiologists would point out that the heart shadow has become diffused. You can no longer see a clear-cut cardiac shadow, nor can you see a clear-cut aortic arch as the aorta bends back into the shot. So left upper lobal pneumonia. The rest of the lung seems fine. This looks okay, but here we've got the left upper lobal pneumonia. This is the same patient actually from the side, and I think you can see here that there's a line. So below, but this is the lower left lobe here, and this is the upper left lobe above here, and this area here is all consolidated. Remember, the air is the dark part, the fluid is the light part. So you can see the outline there of the lower left lobe with air in it, and you can see the outline here of the same outline, of course, of the upper left lobe, which is affected by the bronchopneumonia. A bit complicated, this shot, really, because this structure here is actually the right lung herniating across into the left lung space. But I think you can see the outline there and the lobe affected here, left upper lobal pneumonia. This shot shows a right upper lobal pneumonia. And I think you can see here that in the right lobe it's much lighter due to the consolidation, whereas the left lobe here on the equivalent position is a nice dark colour due to the air. So right upper lobe consolidation. What we're looking at here is a normal chest x-ray of a patient who was x-rayed before the onset of the condition. So I'm not a radiologist, but as far as I can see that's a normal chest x-ray. Going on to the next x-ray, we see the patient with very extensive diffuse consolidation. Now, it's not like the last shots. You can't say, well, it's that bit or that bit or that bit or that bit. But the whole thing, I don't know if you can see it, but the whole thing is like cotton woolly, like it's got cotton wool. It's like diffuse areas of consolidation, affecting both lungs equally. So it's a diffuse bronchopneumonia. So unlike the last sorts that were restricted to one lobe, this is a bilateral condition affecting all of the bronchial tree, patchy consolidation, absolute classic picture that you would see in bronchopneumonia. And just comparing the two together, I think you can probably see the difference now. Ordinary, normal, severe bronchopneumonia. And I'm pleased to be able to tell you that this patient, after treatment, did in fact make a full recovery. So, going back to where we were a few minutes ago, two forms occur, bronchopneumonia and lobar pneumonia. That is one way to classify it. And the other way, as we've said, is by the etiological organism. So people will talk about pneumococcal pneumonia, or, well, actually pneumococcal is a form of streptococcus. But they describe the pneumonia depending on the etiological causative organism. Let's now go on and look at the nature of pneumonia and the treatment and the prevention in more detail. And what I'm going to do in this talk is focus primarily on bronchopneumonia, but a lot of what I'm going to say applies to lobar pneumonia as well. Then at the end, what we'll do is we'll just say something specifically about lobar pneumonia. So most of what I'm going to say applies to pneumonia in general, but I'm going to focus now on the condition of bronchopneumonia. So, pus in many of the bronchi in both lungs is a feature. Pus, of course, typically occurs after bacterial infection. Of course, viruses can cause pneumonia as well, but we're dealing with common features here. In bronchopneumonia, there's many small areas of infection and inflammation, and the patchy consolidation we've just seen diagrammatically and on the chest x-ray. The condition is sometimes more marked at the bases in bronchopneumonia, whereas in lobar pneumonia, of course, it would be most marked over the affected lobe. So sometimes more affected at the bases in bronchopneumonia, but not necessarily. Many kinds of viruses, bacteria, and indeed mycoplasms can cause it. Although, as we'll see later on, the most common sort is the pneumococcal. And bronchopneumonia, this is a very interesting point, mostly affects infants and old people. And as I said before, this is a major cause of death in children under the age of 4. Take chest infections seriously in young children, they can kill them. Very common And then it seems if you survive being an infant, then young adults don't get bronchopneumonia very often, and you get it in old people as well. And times when you might get bronchopneumonia is after viral infections. Viral infections seem to leave the person vulnerable to a superimposed bacterial bronchopneumonia. Certainly after aspiration, if you inhale any foreign material such as your own vomit, as we saw classically causing the segmental pneumonia. But in people that are generally immobile, are lying around on the back and don't cough up the secretions, then bronchopneumonia can develop. In that case, it's often described as hypostatic pneumonia. So it often starts as a virus, especially in the young and old, as we've said. And it's useful to think about when there's increased risks. When do we need to guard against the possibility of pneumonia? Well, when the patients are immobile for whatever reason, especially if they're lying on the back. It's much better for pulmonary function and clearing of secretions that the patient is sitting up. Any condition where you have pre-existing lung disease, such as cystic fibrosis or chronic bronchitis. Conditions where you have excessive mucus secretions, such as allergies. And any condition where you have a suppressed cough reflex. So all people with increased risks of pneumonia. And because this is important that we prevent conditions rather than treat them, we'll look at this in detail later on in the talk. And the important point here is there's a whole range of possible etiological organisms. Actually, some organisms which aren't very pathogenic can cause pneumonia in susceptible individuals. And in aspiration, of course, you're inhaling lots of nasty things into your lungs, so it's not surprising that they become infected. So when pneumonia occurs as a complication of bed rest or immobility, it's sometimes referred to as hypostatic pneumonia. And indeed, it's a common finding, an incidental finding after death in the post-mortem situation. Because most people that die have had a period of severe illness before death, and usually, well, clearly that would be associated with immobility. So the combination of other illness and immobility often means that a degree of bronchopneumonia will develop. And in fact, very often it may be the pneumonia which is the actual final cause of death in a patient with other pathologies such as cancer, for example. So it is a common incidental finding after death due to the immobility and the illness which has just resulted in the death of the individual. So pneumonia can complicate other conditions, and occasionally the infection can spread from the lungs to other parts of the body. This is particularly the case with staphylococcal infection. Not that common, staphylococcal pneumonia, but it does occur. And these abscesses, the bacteria can break off and metastasize to other parts of the body, leading to abscess formation in other parts of the body if the condition is not treated. Let's now consider the signs and symptoms in pneumonia. Basically, the patient is very ill, and very often it's a fairly acute onset. Very ill, usually because it's an infection with a high temperature, 39.5, 39.5, something like that. Degrees centigrade will be typical. It could be higher or lower. Very ill patient, temperature. And there may be some difficulty in breathing as well. There may be fast breathing. And if there's any pleuritic involvement, as in lobar pneumonia, pain. But the pain comes from the pleuritic involvement. Very often in bronchopneumonia, you don't get pain because there's no pleuritic involvement. So basically, you've got a large organ of the body which is inflamed, it's infected, so you feel ill, you get local symptoms from that, and, what did I say? Pain, you feel ill, that's right, the pyrexia. And of course the other thing, because the chest is involved, cough is a main feature. Now typically, at the onset of the disease, the cough is painful and irritating, but not very productive. But later in the disease, in the evolution of the condition, the cough becomes very productive and you start coughing up lots and lots of secretions. So they're the main things. But let's just run down those now and look at them in a little more detail. Fairly sudden onset of chill. Of course, you feel chilled when your temperature starts to rise. Followed by fever, typically a fairly high fever, depending on the etiological organism. There may be varying degrees of difficulty breathing. And especially if there's any pain, there'll be increased shallow respiratory rate because you try and protect the sore bit of the chest from moving too much. But anyway, in bronchopneumonia, you do get a degree of increased respiratory rate and sometimes shallow respirations. And the respiratory rate does tend to rise out of proportion to the temperature, as you would expect, because it's the lung which is primarily involved. There tends to be an increase in pulse rate, as you would expect in a pyrexia. And the cough is often unproductive initially, but very productive later on, and may be associated with crepitations, crackly sounds in the affected airways. So in lobar pneumonia that would be localised, in bronchopneumonia that would be diffuse, perhaps more prominent at the lung bases. Patient may well be pale, have a pallor, and will certainly feel unwell, they'll certainly have malaise. If the hypoxemia is severe, the patient will be cyanosed. And the colour and consistency of the sputum will vary with the causative organism. Usually it will be tenacious. There may be blood-streaked sputum. The sputum will be purulent, it'll be bacterially infected, and there'll be white cells in it, pussy, purulent type sputum. And very often, especially when the etiological organism is pneumococcal, the sputum can be rusty coloured. So purulent, possibly blood-streaked sputum, possibly rust-coloured sputum. Of course, the patient will feel weak and ill. And as with any infection, there may be headache and generally achy joints, and you just feel terrible. But one thing that is characteristic of pneumonia is that they very often develop cold sores around the mouth due to reactivation of a herpes simplex virus, often occurring about the second day into the condition. But as we said, the main features are ill patient, pyrexial, dry cough productive later, purulent sputum, possibly rusty coloured sputum, rapid breathing movements, and pain if there is pleuritic involvement of the pleural membranes. Let's go straight on to etiology. Now, you could have a huge list of them, but most pneumonias are caused by Streptococcus pneumoniae. And actually, I've been referring to it by its sort of more common name, pneumococcus. It's the same thing. Strep pneumoniae is the pneumococcus. So most pneumonia is caused by pneumococcus, Streptococcus pneumoniae. In fact, virtually all lobar pneumonias are caused by this, over 90% of lobar pneumonias, and perhaps something like 50% of bronchopneumonias. Mycoplasm pneumoniae may cause pneumonia, the mycoplasms. These sometimes are reported to have a slower onset. Influenza A virus, possible etiological organism. The Haemophilus also. The chlamydia pneumoniae. Staph, as we've mentioned, Staphylococcus aureus. And the pneumocystis carnii, the pneumocystis type pneumonia, when might you see that, do you think? When do you see pneumocystis pneumonia? Well, the answer is typically in people with HIV. For some reason, seem to get the pneumocystis type of pneumonia. Many other possible etiological organisms, I've just listed a few of the common ones here. But in patients that are immunosuppressed or immobile, relatively non-pathogenic organisms can also be etiological. Now, obviously, it's better if we can prevent pneumonia than treating it. So what I want to look now is how we can prevent it. And what I'm going to look at is, mostly in this section, is a list of things where pneumonia is more likely to occur, when we need to be aware that it's a possibility and then take steps to guard against it. So, prevention of pneumonia. Well, general health and vaccination is important, because pneumonia often occurs in children after measles. So I wouldn't say vaccinate against measles to prevent pneumonia, but if you do vaccinate against these things, pneumonia will be less common. Very, very common that, especially in developing countries, that pneumonia follows measles. And there are pneumococcal vaccines available that may be used selectively in patients that are particularly high risk, if that is available. But now let's go and look at conditions in where pneumonia is more common. More common in, well, any patients with bronchial obstruction, for whatever reason. So, for example, in patients with cancers, very often, not very often, but it does happen that the presenting symptom is intractable infection, because the infection can't get past the tumour and it's causing stasis. So more common in any condition which causes bronchial obstruction. Of course, any time where there's aspiration, for whatever reason. For example, aspiration can occur due to esophageal obstruction. Any condition where the bulbar apparatus, the swallowing muscles and the swallowing anatomy is not working properly and saliva and things can dribble down into the trachea. In cystic fibrosis, the secretions are too viscous. Remember, cystic fibrosis is called mucoviscidosis, viscous mucus, and that can't be cleared properly. And the fact that it can't be cleared means that it's more likely to become infected. Because this is a common principle, isn't it? Stasis leads to infection. Wherever you have stasis, then infection inevitably follows. So if for whatever reason the bronchial secretions are not being wafted up into the trachea and coughed out, you're getting accumulation of bronchial secretions, then sooner or later they're going to become infected. And this is the case with cystic fibrosis. Because the secretions are too thick to get out properly, efficiently, then they do tend to become infected. So people with cystic fibrosis are at increased risk of developing pneumonia. Any patients that are ill and immobile, especially if they're being nursed on their backs. Any condition where there's immunosuppression. And intravenous drug users are more prone to pneumonia. Not sure why, but they are. Patients with chronic bronchitis, again, often have fibrous tissue inside, scar tissue inside their bronchioles, fibrous scar tissue. And again, this can delay the clearing of secretion. So patients with chronic bronchitis, more at risk. And of course, anyone that's malnourished, for whatever reason,